It's been 2 years. We're tired. We're burnt out. We're just trying to get by. But today is the day. It's time to reclaim your rhythm. Pick your playlist and put on your favorite red look. With your jams turned up, get moving. Bring the good vibes and take back control of your health and mental well-being. Little steps add up to big changes. From dancing with your kids in the kitchen to grooving with your girlfriends, staying active is one of the best ways to keep your body and mind healthy. Stress can lead to unhealthy habits, and managing stress means managing your health. So reclaim control of your schedule and build in time to invest in a healthier you. Know your numbers and make moves to help keep your blood pressure on track. Go Red for Women will be here every step of the way. So let's do this together and create healthy habits today that will lead to healthier tomorrows. How will you reclaim your rhythm?
Good evening and welcome to this evening's program, Heart to Heart. February is Heart Month, and we're so grateful you've chosen to join us for our dialogue this evening, led by physicians from Northwell Health. Before we begin, I'd like to thank our Go Red for Women sponsors, including national sponsor CVS Health, and locally our Live Fierce Take Action sponsor, White Plains Hospital, our Live Fierce Go Red sponsor, Northwell Health, and Morgan Stanley. With their support, Go Red can focus on driving women's health in our community through raising awareness of women's #1 health threat, providing tools to women to reduce their risk, improving representation of women in research, and removing barriers and improving access to care for all. During Heart Month, the American Heart Association is asking people to do just one thing to reclaim their rhythm and take control of your health. Share one thing you're doing to reclaim your rhythm this month in the chat. So speaking of the chat, that is where you can ask your questions of the physicians this evening and interact with one another. So please be sure to select that you're chatting with everyone, and we will be able to see those and direct them and get your questions answered this evening. So one thing that you could be doing is joining us here tonight, and we're so pleased that you've chosen to do so. You're taking a step for your own health and a step to advance Go Red for Women's mission. So that we can continue this work, we're asking you to take a moment and make a gift to the Go Red for Women movement and help save women's lives. Please find your cell phone and text Go Red 914 to 41444 and make a gift. It's up on the screen as well. Heart disease is the #1 killer of women, taking the lives of more women than all forms of cancer combined. Your gift supports the Heart Association's critical work so that all women can live longer, healthier lives. Again, please text Go Red 914 to 41444 and make a gift. And now that I'm on video, I was having some technical difficulties there. Perfect timing, because now we can really get to the focus of the program. I want to introduce our moderator, first and foremost, Dr. Dina Katz, a cardiologist with Northwell Health, and our panelists, Dr. Subi Chowdhury, and Director of the Electrophysiology Lab at Northern Westchester Hospital, and Dr. Carl Reimers, Director of the Cardiac Catheterization Lab at Northern Westchester Hospital. Before I hand things over to Dr. Katz, again, just a reminder, you can share your thoughts, comments, and interact in the chat. And we have reserved time for questions and answers at the end of the program, so we will be sure to answer those for you. And with that, I welcome Dr. Katz, Dr. Chowdhury, and Dr. Reimers to come on camera and join us for this evening's program.
Hi, everyone. Thank you, Megan, so much for the introduction. And it's good that we can see you now. And welcome, everyone. Thank you for taking the time out tonight to discuss women's heart disease. We know it's a very important issue, 365 days a year. not just during Heart Month, but it is great that it's February and it's linked in with Valentine's Day. So I was going to start with a poll, but Megan, you stole my thunder, and you did tell us that heart disease is the leading cause of women. And we sometimes get tripped up on that because when we poll people about this, the usual answer is cancer. They think that women die mainly from cancer, specifically breast cancer, but actually it's heart disease. Even during COVID, COVID was not the #1 killer of people. It has remained heart disease. So I'm not going to bore you with a bunch of statistics because I know Heart Month often comes with statistics about women. But there's one statistic in particular that I do like, and I've nicknamed it. I call it the Lady 80. So it's known that about every 80 seconds, a woman dies of heart disease. That's bad news. However, the very good news is that 80% of these deaths are preventable. So you're going to hear us speak a lot tonight about things like atherosclerosis. So I just want to tell you what it is we're preventing. You'll hear us say atherosclerosis, coronary plaque, cholesterol plaque, obstruction, blockage. It's all semantics. What we're trying to prevent is cholesterol from sitting in a heart artery or a brain artery or elsewhere and occluding the blood supply to that organ. So when you hear us say that, it's all interchangeable. That's what we're trying to prevent. And this prevention really should start early in childhood, because that's when these plaques start. In adolescence, we can start putting down plaque called fatty streaks in the arteries. So we really have to focus on kids as well, although I'm all glad you're here tonight as well. I was asked to also address, when should you see a cardiologist? Well, I'm a cardiologist. So my answer is, if you have a heart, see a cardiologist. But really, the answer is, certainly if you have an identifiable risk factor for heart disease, then you should seek the care of a cardiologist at least once. So what are these risk factors? We can really categorize them in many ways. The way that I like to do it is non-modifiable and modifiable. So the non-modifiable ones, well, that's your family history. As they say, you can't pick your parents. And I'm sure your parents also, if they gave you the genes for heart disease, they gave you the genes for some fabulous things as well. So if you have a family history of heart disease, and we consider premature heart disease in a woman who's developed heart disease less than age 65. Remember, women, we develop heart disease in general about 10 years later than men because of hormonal issues. And a first-degree relative male has heart disease less than age 55, that's considered premature. So definitely seek cardiovascular expertise if you have that in your family. And then there's modifiable risk factors that would also seek attention. And I think the most modifiable is cigarette smoking. Then also things like high blood pressure, which is hypertension, high cholesterol, obesity, also diabetes or any diabetic consequence. And there's also female-specific risk factors, which we'll go over. Now, they're all linked together. Things like obesity, sedentary lifestyle, poor diet, everything is linked. The female-specific risk factors are things like pregnancy-induced disorders, like having high blood pressure during pregnancy, having diabetes during pregnancy. And of course, women also have a higher rate of inflammatory disorders and rheumatologic disorders like lupus and like rheumatoid arthritis. And those are also risk factors to develop heart disease at a later time in life. So if you have any of those risk factors at all, I would say seek the care of a cardiologist. So I'm a cardiologist, and I consider myself the general contractor of cardiology. I see people for prevention. I see people with established heart disease. But even in a perfect world, if we can try to prevent everything, remember we said only 80% of this disease was preventable, we're going to have heart disease. And that's when I call in my specialist. So I call in my plumber and I call in my electrician. So I'd like you at this point to introduce you to my plumber, one of my favorites, and one of my favorite electricians. So we'll start with the plumber. Carl, if you wouldn't mind introducing yourself and telling us what you do.
Hi, my name is Carl Reimers, and I'm an interventional cardiologist. So I'm the plumber of the heart. What we do is, in the extreme cases of patients coming in with heart attacks, we bring them up to an X-ray suite, which is a combination of an intensive care unit and an X-ray suite. And we find that acute blockage and take care of it, open it up, put in a stent, ensure that blood flow, supplies the heart muscle, and we open up the artery, give that heart muscle a chance to survive. And obviously a lot of this is going to talk about prevention, so hopefully most people won't end up needing a plumber like me, but also we'll talk a little bit tonight about how we could definitely help you also in terms of symptoms.
Great, thank you. And Subi, our electrician, would you mind introducing yourself and telling us a little bit about what an electrophysiologist does?
Yeah, hi, thanks, Dina. So I'm Subi Chaudhry. I'm the director of the electrophysiology lab at Northern Westchester Hospital. So what we do in electrophysiology is a little bit more, I guess, less well known than what Dr. Reimers does. We deal with the electrical signal of the heart, so that could be any kinds of abnormal heart rhythms. So fast heart rhythms, slow heart rhythms, or irregular heart rhythms. And as we'll touch on a little bit later, these can cause a bunch of other issues, including increasing your risk for stroke and things like that. So we have various treatments that we use to treat these, including pacemakers and defibrillators, which are some of the procedures I do, and also specialized procedures called ablation procedures, where you can find abnormal electrical tissue and either cauterize it or freeze it, so it doesn't, to cure the abnormal heart rhythms.
Thanks, Subi. Well, we certainly have great technology, and we'll get into a little bit more of that. But let's start with the basics. Let's talk about, how do we identify whether or not we have a heart problem? What would be some of the symptoms that women as well as men should be looking out for in order to seek medical attention?
I think that one of the challenges for women with heart disease is they often present a little bit differently than men. Men typically have more of the classic symptoms of a weight, a heaviness in the chest. And it's not a pinpoint sort of pain, but a generalized feeling of heaviness all over. Can go down the left arm, can be associated with some sweating, some nausea, and so forth. Women often present with symptoms that are a little bit different, more sort of an epigastric or upper stomach type pain. And I think one of the things that is disturbing to me is that this has been very well recognized by the media, which is that women present with slightly different symptoms, and yet many physicians fail to recognize that this could be a heart-related issue. And so it really takes the woman to be her advocate to say, wait a minute, could this be a heart-related issue? And to find someone like you, Dina, a cardiologist, to say, that's a possibility.
Yeah, I agree with you. A couple of things about symptoms. So I do agree that women can present differently, but indeed we're more similar. Men and women are more similar in their presentation. However, women can have, as you said, nausea, shortness of breath, feel flu-like, have back pain. And I just want to tell you anecdotally, and this is only anecdotally, when a woman tells me they think their bra is on too tight, I think heart disease. So I mean, wow. I have had a few women who have had resizing and then felt better, but in general, I find that to be a key thing. And also, you're right about this. Women, have a delay in diagnosis. They've actually done studies on patients who presented to the emergency room with symptoms that were pretty classic for heart disease. And what they found that was about 3.4% of men got sent home from the emergency room. That's not a big number, but when we're dealing with a heart attack, anyone who gets sent home from an ER, that's a problem. And I'm sorry, I'm mistaken. It's 3.4% of females have gotten sent home. Right. On the other hand, it's 1.4% of men. And again, that's a big disparity. So I think we do have to do better at recognizing these symptoms in women.
I will say,
Yeah,
Dina, the other thing is that, you know, but we often find that women present having heart attacks and they present late, meaning they started to have the heart attack hours ago and they present very late, and therefore their outcomes are not necessarily better than men. Women present later typically because of the hormonal issues you were speaking of, and they also may present with slightly different symptoms. But when you get down to the basic disease, you know, from a disease point of view, the way we treat it is remarkably the same. It's just identifying, you know, the patients who are having a heart issue, and, you know, making sure they seek timely, and timely is the key word here, because time is muscle, timely, you know, evaluation and treatment.
Yes, and even when you get to the emergency room, you know, there's certain tests we do. We're talking about an acute setting, by the way. We can also talk about chronic heart disease in a bit too. But say you go to the hospital with chest discomfort as a woman, and they do identify this as a potential heart attack. We do a blood test. It's called a troponin. And the troponin measures any damage, even if it's very mild damage to the heart muscle cells. Well, troponin levels are different in men and in women. And we do not, to this day, have sex-specific guidelines for troponins. And I think that's a real issue, too, that has been starting to be recognized. So we do miss some heart attacks on women just because this level is really geared to men.
yeah.
So, Dr. Chowdhury, what's your interpretation, your impression of women presenting with acute coronary syndromes?
Yeah, so I mean, acute coronary syndromes, it's well known. I think at least in our fields in cardiology and I think it's been well publicized that women's symptoms, women often present with different symptoms and often are underdiagnosed or diagnosed late, which leads to worse outcomes. And it's the same actually in the electrical field that I deal with. The most common thing that we deal with is atrial fibrillation, which has been seen, which more and more people know about now because of all the commercials for the blood thinners, and because now your Apple Watch or your smartwatch can detect atrial fibrillation. But a lot of that is also under detected or diagnosed later in women, also because many of the times they present with different symptoms. So it's oftentimes not the classic, I feel my heart racing or jumping or beating funny, or I'm having a lot of shortness of breath, but they often present with fatigue or feeling tired or just not quite feeling themselves. And it's only after multiple investigations that they end up with the diagnosis of atrial fibrillation. And the same as what you deal with, Carl, what I deal with, as you delay the diagnosis and the later you make the diagnosis, the more difficult it is to treat and the worse the outcomes down the line. So it's important to try to diagnose and recognize this stuff as early as possible. That way we can get the most effective treatments and most effective outcomes.
Right, so why do women present later than men? I mean, is it the woman's fault? I mean, I hate to use the word fault, but is it us? Or is it?
No, I don't think it's the woman's fault. I think it is, again, I think it's our fault. I think as a profession, I think that we have collectively somehow missed that big line of, hey, guess what? Heart disease is the biggest killer of women. And for some reason, it doesn't seem to get a lot of traction. And I don't understand why. And I mean, this is exactly the point of why we're here right now, which is to educate people that yes, indeed, women present early with breast cancer, ovarian cancer, terrible diseases. I understand that, but heart disease is also still a very major consideration. And so I think the very point of something like this is to try to educate the population to say, hey, it is a risk factor. And by the way, we do see women in their 40s, sometimes younger, but in their 40s who present with heart disease. So don't just think that, hey, I'm 45, I have this discomfort, there's no way it could be your heart, because there are people who present early, and it is something that should just be in the back of your mind. Going back to us as a profession, I think there are a lot of, and again, I don't want to disparage other physicians at all, but I think it's been fairly well documented that cardiologists tend to pick up on heart disease a little bit earlier than your typical general practitioner, which is understandable because they're thinking, in a very wide spectrum, and we really focus and we hear some catchphrases and key things to say, ooh, hey, this could be this. And so I'm not trying to, again, disparage general practitioners in any way. All I'm saying is that we as a profession need to get this message out.
Right. And also, what I'm alluding to also is that we have to be our own advocates, women. Yes, we rely on our physicians, but we have to take charge. If something doesn't feel right, we have to report it and we have to continue. Even if a doctor says, oh, you're fine, and it's just hormonal or whatever, and you think something's wrong, you are your own advocate and you continue to seek attention. And I think the other thing is that women, it's not a stereotype, but we're very busy, and most of us are very good at multitasking. We take care of family and kids and spouses and pets and jobs, and it just goes on and on and on. And there are still some social stereotypes where we do the cooking and we do the cleaning, and that's just the way life is. And so women, I think, also present later because they care for everyone else first. And I think something like this, Women's Heart Month, is really telling us, women, take a stand for yourself. Really, you have to be healthy in order to be that caretaker for everyone else. So I do think it's a combination, Carl.
I really like what you just said, because one of the things I often tell patients, the two things I often tell patients is, sometimes I have a relatively young woman come to my office and they say, I feel foolish, it seems silly. I do a workup, I find nothing. I was like, that's not silly, that was smart. And the other part of it is that if you're not healthy and you're the care provider for your entire family, but if you're not healthy, you can't take care of them. Like, you got to think about yourself first, which is exactly what you were just alluding to.
Right. And there are, I'm sure you see this all the time in the lab, Carl and Subi, in your clinical practice as well, that women do have different characteristics of their blood vessels. Yes, we get blockages like men have. Sure, we get that atherosclerosis, that plaque that can occlude a blood vessel. But we have a higher incidence of having normal arteries. When you shoot some dye into somebody's heart artery and they have all the symptoms of having a heart attack, but you don't find a blockage, we found that women have microvascular disease. There doesn't have to be a blockage. There can be some abnormal reactivity to the blood vessel. There can be some spasm to the blood vessel. There are times there's dissection in a blood vessel. Clearly not as common as what Carl sees on a day-to-day basis of plaque, but these are also things that need to be thought of, or we won't find them in women.
I'd like to ask Scooby what he thinks is the biggest difference between men and women from his electrophysiologic perspective.
Yeah, so I mean, again, the biggest difference I think is that we often see women presenting later, and part of it is due to a reluctance or writing something off as normal or something that's not a big deal. And if it's not a big deal, I don't need to seek treatment until it is a big deal. And we don't have a lot of for things like other big diseases in women like breast cancer. There are it's been publicized that you have a screening program for colon cancer for men and women. You have a screening program where you can detect things even when they are not there to routinely be detected. For cardiac disease, oftentimes men come to us for symptoms or for risk factors. Women, we see less, for the risk factors, and for symptoms, often, again, a lot of the symptoms are less specific or more non-specific. Things like fatigue and being tired, people will write off to other things rather than an abnormal heart rhythm. And you're less likely to seek medical care. Along those lines, I mean, even we do have some screening tools for cardiac disease, not necessarily for abnormal heart rhythm stuff, but there's been more and more use of coronary calcium scoring and things like that. What do you guys feel about doing things like that as a screening test? And I know for men we use it a lot. Is there what's the role in women a coronary calcium scoring, when would you recommend it, and when would you say? Oftentimes it's not covered by insurance, but I know a lot of the places, radiology places around us, do it for maybe $100 or somewhere around $100. Is there a role for doing something like that?
I'll take that one. That you hit on the prevention. I love that, Subi. Thank you. And I didn't feed him that question either, I have to tell you. That's a real question. So yes, I love the new technology we have, calcium score test and CT angiography. And as a preventative cardiologist, I use this frequently. The calcium score test, as you said, is not covered by any insurance at all. It's considered a screening test. However, we are so lucky to have this technology at Northwell for $75, an out-of-charge fee to the hospital, which is, I mean, it's so well worth it. And it shows us if there's any preclinical, that word again, atherosclerosis, so in other words, preclinical is you haven't come to the fore yet, you maybe didn't have chest pain, you don't have shortness of breath, but you have some plaque in your arteries. And hey, this is time that we have to take control. And we know as cardiologists, we have to be super aggressive with your risk factor modification. We might want to start you on a statin drug. We definitely want to get you to a nutritionist, have you exercise regularly, and follow you closely. And then there is a test that takes a little bit longer, a little bit more involved, which is called the CT angiogram. And that one will show us more exactly where the plaque is. It actually looks like what Carl does in the lab when he does his angiograms, except it's done through a CAT scan. And that one, again, takes a little longer, has some radiation, does involve intravenous dye injection. And I usually reserve that for people who are having symptoms, and I really suspect that they have heart artery disease. But yes, Subi, thank you. I think those are great tools.
Yeah, and again, just for everybody, that's a coronary calcium score, or it's a simple CAT scan that checks the amount of calcium in the heart arteries.
So we can't end this discussion without addressing one other thing, which is stress. And now, Subi, someone like you're seeing people for palpitations quite frequently, I imagine, even shortness of breath, chest discomfort. I mean, how do you handle this? Those are the same symptoms that we have from stress. And are they linked to the diseases that you treat?
Yes, and you know, stress is I was going to say a double-edged sword, but I guess it's all bad. But we live in New York, and stress is unavoidable. So stress causes a lot of these symptoms, and a lot of people attribute their symptoms to increased stress. And it may just be that stress is making your heart pound, and stress is making you feel like this. But whenever anybody comes to me with those kind of symptoms and attributes them to stress, oftentimes they're not, and it's tough to quantify exactly, because for one specific person, it's going to be either a real abnormal rhythm, or it may be because of stress. But it oftentimes we have non-invasive tests and very simple tests that we can do to differentiate whether or not there's a dangerous heart rhythm, or even a worrisome heart rhythm that's going to continue. I can tell you, even in much younger women in their 20s, there are people who are on anxiety medications or other medications who come to me saying, "Oh, it was just." People have been telling me for years that I have panic attacks or anxiety episodes, and you end up finding it's actually an abnormal heart rhythm. And they've been taking these medicines for years, and they've been helping somewhat, but not really all the time. And then you treat the abnormal heart rhythm, and all of a sudden they feel much better. So these kind of symptoms we can't write off in any circumstance, and it's easy enough to get tested. It's easy enough to do simple tests to tell you what these symptoms actually are. Sometimes, and not to belabor, but sometimes it's not just abnormal heart rhythm. Sometimes people come to me for palpitations, and it'll be maybe extra beats or abnormal heart rhythms that aren't very worrisome from a heart rhythm perspective, but those can sometimes point you in other directions, and people have increased frequency of these extra beats or increase in these symptoms because of things that have nothing to do with the heart rhythm, but may indicate a valve problem or a coronary problem. And oftentimes it's those less quote unquote less worrisome symptoms that uncover much more dangerous issues.
Sure, thank you. Yeah, and I think a good tie-in for all of that is exercise, and one of my favorite things to do, yoga. And I know I've read some studies about yoga being beneficial to decrease the amount of AFib you have, and to decrease the episodes and the symptomatic episodes of AFib, and also decrease the stress. So I just want to put a plug in for daily regular exercise, and for yoga and stress management, and even a little meditation. What do you guys think about that?
Can't hurt.
We're all heart doctors. We love exercise.
Absolutely.
All right, so I think we're getting some questions in the chat box. So would you mind if we address some of those now?
Sure.
Right. So there's a question here about smoking as a risk factor of heart disease. We know that does play a very important part, but this question is about regarding nutrition. Is nutrition and exercise, oh, very timely, we just did that one. Is nutrition and exercise just as important?
Well, I think you're better prepared to answer that one than the rest of us, right?
Well, I have to say you're talking to an herbivore right here. Yeah. So I do believe that nutrition, it plays a very big part in our health, especially our cardiovascular health. And I am a vegan, not a crazy vegan. You know, I will have the chicken sit next to my vegetable and not go crazy. But there are some fantastic medical studies on limiting cardiovascular disease with a vegan diet. Now, you don't have to be vegan, but food is medicine. What we put in is how our body functions. The Mediterranean diet is a phenomenal eating plan as well. And definitely there's fantastic data on that. The PREDIMED study is one of them that shows that if you increase olive oil, fruits, vegetables, whole grains in your diet, and just decrease a little bit of the saturated fats that you would find in meats and dairy products, you live longer. So you really can't beat those studies at all. So yes, I think nutrition and exercise are as important. However, smoking is the first thing I always address. I don't find any reason for anyone in 2022 to smoke cigarettes. Even one cigarette can cause a blood clot in an artery that can lead to a heart attack. So
I would like to say one thing though quickly about smoking. There are, people who have been smoking for a long time, and it is almost impossible for them to give up completely. And one of the things I say is, obviously, please quit completely, because that is what you really should be doing. But you know what? 1 cigarette a day or 2 cigarettes is a lot better than 20. 1 cigarette less per day is the right way to go. And the other thing I say, because I see a lot of people wanting to quit, and I say, however you figure to do it, pick a date and do it.
Pick a date. That's right. Pick a quit date. And we do have some services. Maybe, I don't know if we have them available, but we might, if we do, we can share those in the chat box or maybe later. Northwell has a smoking cessation program, which is free, that you can call into. They have counseling, they have groups, they have many, many tools to help us in order to not smoke. So that, yeah, that's a great point. So I have a question here. Should I incorporate a visit to a cardiologist as part of my routine care at a specific age, or only if I'm experiencing something out of the ordinary? Do you want to take that one, Subi?
Yeah, so I think it depends on the risk factors as well. It used to be that every diabetic over age 50 got a stress test. And we've moved away from that a lot for cost reasons in the country, but it's worth being looked over. And I think at a specific age, I think it's worth discussing whether to have a screening test like a coronary calcium score. It's not something that is again covered by insurance or recommended overall. But if you have specific risk factors, and age by itself is a risk factor, but if you have specific risk factors or worries, it's worth speaking to a cardiologist about what you can do about that. And you may decide not to get a test, or you may decide not to take the medicine that they recommend, or whatever it is. But it's worth knowing the risks and benefits of everything you get into. Because I think there's the one good thing that we have in cardiology is we have tons of studies. So with the tons of studies, we have tons of information, and information is power. You use that knowledge, and you can decide whether or not you want to increase your exercise and eat how you want to eat and what you want to do so that you can live longer, feel better, and feel good for as long as you do live.
I would add that, a history of premature coronary artery disease in a relative, whether it's a parent or a sibling, is a real good reason to try to find a cardiologist, to get screened.
Absolutely, absolutely. And I'm glad you reviewed the calcium score, because we do have a couple of questions about that. The test name is, the screening test is calcium score. That's the one. That's $75. We have a couple of questions about that. Yeah, so I think it's always important to see a general cardiologist if you have any risk factors. As you said, if you have parents or first-degree relatives who've had heart disease. But we also have a bunch of what we call risk-enhancing factors. Besides the ones that I mentioned at the beginning of the talk, like high blood pressure, high cholesterol, obesity, sedentary lifestyle, poor diet, all of those are risk factors. But we now know things like, I know this is a women's talk, but erectile dysfunction in a man. There's arteries all arteries are connected from head to toe. If there's ED, I think a cardiac workup is worthwhile there. That's called a risk enhancing factor. Again, if there's an immune disorder, a rheumatologic disorder, or an inflammatory disorder like rheumatoid arthritis, we now have learned that heart disease is an inflammatory disorder. The blood vessels, the lining of the blood vessel gets inflamed. And when it gets inflamed, it's more prone to clot, and it's more prone to get cholesterol in it. And so that's why it is inflammatory. And we're actually treating heart disease as an inflammatory disorder now. So if you have any of these problems, you should see a cardiologist. I mean, my colleagues here know that we often use aspirin, which is a whole nother talk in itself, but that's an anti-inflammatory. And we've even started using colchicine for some types of heart disease. And you might recognize that name because that's an old-fashioned gout medicine. But again, it's an anti-inflammatory. So there are these other markers. There's probably about 15 we call them risk-enhancing factors, that when you see the cardiologist, he or she will go through a checklist of other things that you may have that would make you more prone to develop heart disease at a later age. And when we do identify that, we are even that much more aggressive at treating heart disease. I don't know if we can be much more aggressive, but we're aggressive. So let's, I don't have many other questions here. So let's just spend a minute about the treatment of heart disease. So say we've found that there is heart disease. Carl, Subi, you found and fixed some problems. I mean, is there really a fix there? What do we have to do going forward? And we know that women in general, even after they're diagnosed, are prescribed medications less than men. Simple things, simple to us, like aspirins and statins are prescribed lower in a lower rate with women than men. So can either of you discuss that a little bit for us?
I would say that my treatment of women is the same as men when it comes down to, if I have a woman who is asymptomatic with, a positive coronary calcium score, but again has no symptoms, I would review the risk factors, but there's no question that I still would recommend a baby aspirin and a lipid lowering therapy. The best ones out there still are the statins. And again, that in and of itself is another conversation as well. But to me, once the diagnosis is made, then, you want to treat it so that you don't end up seeing me. So if we find that, you have coronary calcium, which means you have plaque, but you're able to exercise and do yoga and so forth, great. We want to have you on the baby aspirin to try to prevent first heart attacks, and the statin to lower the cholesterol and prevent the buildup of plaque, so that one day you don't get symptoms or present with a heart attack and end up in my Cath Lab and end up getting a stent, which, by the way, is not the worst thing in the world, but we like to prevent that as well.
Yeah, and I'm sorry, go ahead, Subi.
Sorry, just to jump on that. What I always, everybody, I often see patients, because I see some general cardiology as well, that come to me, and they always say, oh, well, the calcium score is only this, or there's only a little bit of plaque. Do I still need to take the cholesterol medicine? I don't want to take the cholesterol medicine. And, I grew up in Dutchess County in Hopewell Junction, and we had hard water from the well, and if you didn't have a water softener you'd get buildup, you'd get blockage of the pipes, and you could break down the wall and replace the pipes, but we don't want to get to that stage, and we don't. What we're trying to do with a lot of these medicines and the statin medicines happen to be the best at doing this and the best proven at doing this, is not just to treat that little bit of plaque. That little bit of plaque is not going to leave the artery and somehow magically disappear. Sometimes you can get it to regress a little bit, but what you want to do is prevent it from causing an issue, prevent it from obstructing blood flow, prevent it from rupturing and causing a blood clot to form, which will cause an acute heart attack. And so it's really it's not about getting your cholesterol down for 1 year, getting your cholesterol down for 6 months, and then we're good. It's about preventing buildup over years and years and years, and reducing your risks over years and years and years. And I think the more evidence we get, the better we're seeing. The people who've been on these medicines for 10 years have a markedly lower risk than those who haven't. And if the guy tells you need to put a special type of gas in your car to keep it running for longer and smoother, we all pay extra to put that special type of gas in our car. But it's the same type of concept with taking these medicines for years and years and years. It's to keep your arteries running well for many, many years.
Yeah, I agree with you. I mean, I think that statins are the greatest thing since penicillin. I see it in my day-to-day practice. The amount of times that I have to rush in to see an acute heart attack since we've started using statins, and I am dating myself, is really diminished. Statins are phenomenal. Now, we all know that statins get bad press, and almost on a daily basis, we do have many discussions about the risks and the benefits of statins. Personally, there is one statistic that I like, and I quote it all the time to my patients, that the side effect profile of a statin is really, really safe. Some people think they have myalgias, which are muscle aches, and some people do, actually, and we have various tricks to manage them. But I often say to people, you know what, keep a diary for me before you start your statin drug. Just keep a log or on your phone about any aches or pains you might have. Because I don't know about you, but by my age, I'm feeling things. My knees hurt, my shoulder might hurt, my fingers might hurt. And, you'd be surprised when you really do look at your symptoms. There are aches and pains that go along with day-to-day life. Naturally, we usually will stay there on a new medication just because it's the first time that we're paying attention. The other thing important about statins, I think, and side effects is that the serious side effect of a statin really occurs in 1 in 100,000 people. Now, that's the same amount of people who die from having a dose of penicillin. So just think about that. When you go, and sometimes you beg the doctor to give you an antibiotic because they don't want to, you're not saying, oh, doc, can I have some amoxicillin? Oh, what's the side effect? Am I going to die from this? So just to put it into perspective.
Dina, one of the things that I do in my practice, if I have a patient who's been on a statin who comes in and says, I'm having a lot of aches and pains and so forth, I say, well, stop it for a month. Because no irreparable harm is going to happen if you're off of that medication for a month. And if those symptoms go away, well, then we found something out. And if they don't go away, then we found something else. Oh, we found out that it's probably not the statin. So, it's a quick check to get some reassurance. And I've had a lot of patients who get reassured that, oh, wow, it was not the statin. And again, I think it points to what you were saying is, the bad press that's out there. There's not enough good press about, I guarantee you, statins have saved more lives than stents have.
And together, they're fantastic, right? You stent when you need to, sure. You statin when you need to, but hopefully one day we'll get to the point where, Carl, you'll be retired by then, but maybe one day we won't need you.
Right, exactly.
Yeah, so I think we only have a little bit of time left. So let me just see if there's any other questions we have here. Oh, this is a great one. I don't know if we do it in the minute or so we have left, but I've been referred to a cardiologist, and what information should I come prepared with? That is a great question.
Subi, you want to take that one?
Well, I'll take, if you have, if your primary doctor hasn't sent your lab values and your family history and that along, you definitely should take that with you, because that's something your cardiologist can review. But you should know your history. You should know your history, know your numbers, and if you take those with you, that's a huge starting point.
Yeah, I agree. Very important to know your numbers, know your lipid panel, your total cholesterol, your HDL, your LDL, and your triglycerides. That's very, very important that we know that. So sometimes you have to do a little searching for that. And definitely ask your family about their history. I'm always surprised that people don't know what their mom and dad had. Certainly not what their grandma and grandpa had. And people always say the same thing. Well, back then, no one talked about it. And I guess that's true. Nobody really talked about their diseases, whereas now it's the first thing we do at the dinner table as we talk about what we have. So things have definitely changed. All right, let me just see if there's if anyone else, Carl, Subi, have anything else you want to add? I'm just looking for any other questions before we have to close it out. Oh, we have the link to the Northern Westchester Hospital Smoking Cessation Support Group. I don't know if that's visible to everyone, but we will get it there. Oh, I have a big one here. What exactly happens in the Cath Lab?
Yeah. So the Cath Lab, this is not major surgery. This is what we call a procedure. And bottom line is that if you need an invasive procedure, then we bring you into an X-ray suite and give you some medication to help you relax. We don't use general anesthesia in general. We just want you sort of in a twilighty kind of thing, but it's less anesthesia than, say, a colonoscopy. And then we use a little lidocaine, numb up a little area in the wrist or the leg, and put a little tube into the artery there. And then using X-ray, we go up to the heart, inject some contrast, and take some pictures and find out what's what. A typical angiogram takes about 15 minutes. A stent, depending on how technically difficult, can be, half an hour or an hour. I will tell you, and obviously I'm a little bit biased, but I will tell you that most people say to me, I thought it was going to be a lot more than that, or it was going to be a lot worse. I think most patients' perspective is great. Now, obviously, we would like to not see you get there. And I think that's most of the point of what we're talking about tonight, is trying to prevent you from coming to see me. But you know what? If you need to have an interventional cardiologist and go to the Cath Lab, again, most people find it to be really not such a bad experience.
And Subi, you also work in the Cath Lab. You don't do cardiac catheterization, but you work in that same lab.
Yeah, I like to call my part the EP lab, the electrophysiology lab. So we do similar types of procedures, but different. I mean, so they're aimed at a different purpose. We also thread catheters, usually through veins, to find and do some electrical testing to find abnormal electrical circuits, and we can cauterize the abnormal electrical circuits. And we also do, aside from that, which is a completely different procedure, and more commonly, but the more common procedures we do are pacemakers and defibrillators, which are actually devices that are implanted under the skin with wires that are threaded down to the heart for various purposes.
I just have to say that I feel so blessed, excited, happy to be able to have both of you so close to where I practice. I'm at Phelps, and both of you are at Northern Westchester Hospital. And previously, I would sometimes have to send my patients other places, down to Manhattan, wherever, up to wherever. And now we have it right here, right in our backyard. So thank you. Thank you both.
Thank you.
Well, we're all a team in Westchester.
Well, I just want to jump on one last time and say thank you to our physicians this evening, Dr. Katz, Dr. Chowdhury, Dr. Reimers. We're so appreciative of your time. As the director of Go Red for Women and the Heart Association here in Westchester, we are grateful for your collaboration and partnership with us. So Thank you to those who have joined us this evening. If there are any questions that we did not address, we will certainly follow up by email with you afterwards. But we just hope you enjoy the rest of Heart Month and we're able to pull some wonderful information out of our program this evening. So thank you. Have a wonderful evening.
Good night.
Thank you.